This is so great, and I am so pleased to be here. Honored and excited and inspired by what's going on here. As Alika was saying, I'm a primary care physician in the VA and also Ahmed trained and at the University of Washington. Let's go to the first slide because I'm here today really kind of just as a private citizen. Do I control the slides? Let's see. There we go, good. So I'm not here as a representative of the VA, and anything I say doesn't reflect the VA or the government or my position as a VA physician. I adore the VA. I've been in the VA my whole career, and we're doing some amazing things. And I want to share some of those with you because they might be relevant to the work being done here in Lahaina and other populations as well, where people have experienced events that turn their lives upside down, impact their family, their health in every way imaginable. And we're trying to help them get back on their feet, which is what we're all trying to do here. So as I was flying over, I was looking at pictures and some of the materials I use when I'm talking about post-deployment care. Because what I've done in the VA, and actually Amy and Heidi and Kiala, I could have happily worked beside you in the clinic, the Lahaina Comprehensive Clinic. I worked for 15 years in a community mental health center where I set up a primary care clinic. So I was working with social workers, case managers, psychiatrists, psychologists. It was really integrated care of the sort you're doing here, which is fabulous. Then in the VA, one of the first things I did was to set up clinics for post-deployment care, which is, and they were integrated care clinics that I'll talk about briefly, to do the exact same thing you're doing, to take care of people coming back from war, again, whose lives have been totally turned upside down. Their health has been impacted in every way imaginable, and we're trying to help them get back on their feet and get connected with a life that's satisfying and meaningful and functional and works for them. So as I looked at the pictures, if you squint your eyes, these are all related to combat, deployment, combat theaters, and so on. The pictures I was looking at from Lahaina after the fire was the same thing. It was the same phenomenon of someone going through something that was so horrifying and so overwhelming, so frightening, and so impactful on their lives in every way that I was hoping maybe some of what I have to offer will be useful for you in your work with folks recovering from this disaster in Lahaina. And I want to thank Alika and Ruben and the staff here for inviting me and setting everything up. I've been very excited about this. So, veterans. I was taking care of veterans for 20 years when I realized most of what I was doing was taking care of health concerns that were related to things they had done, things that had happened to them, and environments that they were working in, deployment, garrison, combat, whatever. And I realized, I'm really kind of doing occupational environmental medicine. So that's how I ended up here talking about exposures and how to assess and manage exposures in individuals. When you look at the sorts of exposures how many veterans here, by the way, if you don't mind raising hands? Hi, so there's maybe a dozen veterans. Yeah, just the experiences that individuals can face during military service and deployment have an impact on health in a way that if we're not veterans, if you're taking care of veterans, you should at least find out if someone has served in the military. And if they have, it gives you a little significant insight into them as a person, into their lives, and into their health risks as well. So these are sort of health risks we see all the time, people coming back from war. So what do we do about it? How do we kind of structure anything around this to provide care that actually works to help a person get back on their feet? When we asked veterans at Fort Lewis McChord, Joint Base Lewis McChord, coming back from Iraq and Afghanistan, because at that point we were trying to set up these post-deployment clinics, integrated post-deployment clinics. What do you need from us? They came in, we said, what do you need? And they said, medical care. Okay, we got that. We can do that. Assistance with compensation pension claim. Financial. Job. I'm getting out of the military. I don't have a job. I don't have an income. And we realized, that's the second most important thing they're needing, and they need both. And then financial, employment, dental. Someone who understands. We need to come to a place where people really get it. People really understand kind of what we've been through, maybe what we're going through now, what we need, That was very striking. And then things like sleep. Mental health is important, but it was, as was mentioned by the staff from the Lahaina Comprehensive Clinic, the idea of treating or assessing and treating someone for PTSD the moment they step out of a traumatic experience is silly. It doesn't work. It's not what they're needing. They're needing to get their feet in the ground. They're needing safety. They're needing a place to live. They're needing something to eat. Down the road, we'll be thinking about that for sure. But the other thing, and I'm old enough that when I started taking care of veterans, we didn't have a term PTSD. That was in the late 80s that came up. But we knew that these experiences changed people's lives in profound ways. So we came up with this constellation of symptoms, and they named it PTSD, and it was very helpful. At the same time, we did a study in my clinic that looked at individuals that had been traumatized in combat. We matched groups with combat traumas, and we did surveys doing PTSD assessments on all of them. The ones that met criteria for PTSD, check, 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 check. Oh, they got PTSD. These folks, same trauma, check, check. They have a couple symptoms, but they don't have PTSD. So the message that people tend to give is, well, you don't have PTSD, you don't have to worry about it. Well, the truth is the group that had some symptoms and didn't meet criteria was at higher risk for suicide than the ones that had PTSD. So the point there that's relevant to our discussion here today is that's where the notion of trauma-informed care, it's the trauma. It's the way these things affect our lives, not whether or not we have PTSD. We have things we can do for PTSD. I did some training early on of mental health folks from Ukraine. And the first thing they were saying is, should we use EMDR? Can we use this or that treatment for PTSD? It's like, well, yeah, there'll be a time for that for sure. But you got to get these people settled back into their communities. You got to get the communities oriented towards what do we do to support these folks, and how do we make sure they have the basics before we think about formal treatment for PTSD and so on. So anyway, this was very informative to us, and it told us that the veterans need the sort of thing that you're doing when they come back from a war that you're doing at your comprehensive clinic here. They need integrated care, team-based care that's really comprehensive in what it does for them. So the way we broke it down with returning combat veterans was we looked at the physical impacts, we looked at the psychological impacts, and we looked at the psychosocial impacts. How does it affect your physical health, your psychological health, and your social situation? And so we know that all those were impacted in different ways, so we wanted to kind of get a sense of what a person went through, because then what we did was this idea of biopsychosocial care. The embodiment of that essentially is having every person was going to have a medical provider, every person is going to have a mental health provider, every person is going to have a social worker, and the way we're going to go about your care is with a team that takes care of all these things. It doesn't matter if you have PTSD or not. It doesn't matter if you don't have any diagnosed mental health condition. If you've been off to war or if you've been through something that the folks here in Lahaina went through, it would be prudent and helpful probably to at least be connected with someone on your team that's knowledgeable about these things. You're not going to get any treatment right now. You maybe don't have a diagnosis. It doesn't matter if you have a diagnosis or not, but you need that on your team. So this was the basic team we came up with. And then, looking at the overall concerns and everything I'm saying about post-deployment care, think Lahaina. What happened to people here? What sorts of things occurred with them, and many of them are similar. And we were just looking at folks, most of whom had this whole constellation of concerns. And so we realized what we need is care that is the red circle, whether it's your clinical team. And there were times that we were seeing 30 new combat veterans a week in my clinic coming back from Iraq and Afghanistan. 30 people that hadn't yet been seen by any mental health provider, similar to what you all been seeing in the clinic as well. And so we tried to figure out how do we put teams together to take all these things into account in an integrated way, so a person's not being sent hither and yon for every different kind of service that they might need, but instead to have a team-based integrated care, both for the individual veteran, but also for the total cohort of veterans in the U.S. Because there were 5 million deployed ultimately to Iraq and Afghanistan, for example. These are large groups of people we're talking about. And also for preparedness, you all were talking about preparedness, trying to figure out what's the way we can upscale this kind of care if we have a big deployment, not if, when we have a big deployment in the future, because it happens every 10, 15, 20 years in the U.S. we have a big deployment. PACT Act came along. So the point of today's talk, this legislation was passed in 2022, and it supported care for veterans with health concerns related to exposures. The whole burn pit thing with Burn Pit 360, a veterans organization, and John Stewart and the first responders, 9/11 first responders, everybody got together and said, hey, these folks got a lot going on, they need some help. PACT Act was really oriented towards taking care of veterans who had any concerns potentially related to toxic exposures, and also supported research, supported a lot of stuff. It was almost unanimously passed. So one section was, you're mandated to screen all 9 million veterans, enrolled veterans, for possible health concerns related to exposures. You know, when I first heard it, I said, that's preposterous. What are we going to do that? And then they asked, well, would you be willing to be the physician lead for this? And I thought, and we had 90 days to put something together. The reason that this worked is because everybody in the VA felt similarly about this common issue in veterans, these common needs that they had, that everybody felt like, I want to be a part of this. I want to make this happen. I want to do what I can do to get these veterans screened and to get them the benefits and services they need. So it may be that, I don't know what sort of processes you're using here at this point, but for us, Section 603, we came up with this thing called TES, Toxic Exposure Screening. And that's what the tool was called, Toxic Exposure Screening, all hands on deck, everybody's involved. Essentially, we're asking the question, what have you experienced? We're not saying, were you exposed to a lot of smoke? Were you burned? We're saying, what did you experience? And what are your concerns? How's it affected your life? What are you needing? So we are screening for exposure concerns, not documented exposures, because most of these exposures aren't quantified. You know, we not only do we not know the full constellation of exposures, but we don't have any exposure data. So what do that was our challenge. What do we find? 46% of veterans said endorsed at least one exposure concern. The reason we picked those 6 bullets, 5 of them they're the most common exposures in veterans. And also for all 5, we have these conditions that have been designated as being presumptively associated with the exposure, which means you don't have to prove how much you were exposed to. You can't. How could you? We have conditions designated as presumptive conditions. If you have one of those and you are involved in the line of fire, let's say if you have presumptive conditions established, and Dr. Cronin was saying they have similar things for 9/11 responders, is that right? Yeah. So we picked these 5 things to screen for because we have presumptive conditions, and we also had registries for 4 of the 5. But we also had other, because going back to that first slide, there are dozens of things people can be exposed to, and we want them to at least be able to document that. So that's what goes in the other category. Here's what it looks like to screen. We've screened 6 million veterans. This is what we've asked them. Do you believe you experienced any toxic exposures such as? And if they say, no, I don't think so, or they say, what do you mean? Then the education starts. Well, what we mean is these exposures are very common in veterans. I noticed you were in Iraq and Afghanistan twice, and there were burn pits there. And because of that, we assume people there may well have been exposed. So there are some conditions. If you develop them, you will be eligible to have support for those conditions. So if they say, I don't know, or if they say, I'm not interested, then we don't screen, and then we rescreen them in a year. So, so what we're doing, we're acknowledging that they have the concerns, we're asking them about the concerns, we're documenting the concerns. And the other thing that happens, excuse me, is if you click the box, and this is a clinical reminder. In the VA, what it means is every veteran that walks in the door, when you start care with them, you assess for suicide. There are certain clinical reminders that you do at least once a year. This is a clinical reminder that we were going to do on all 6 million veterans. So when you click the box, let's say Agent Orange, then a list of all the presumptive conditions and links to information pop down as well. So you immediately begin the education process, the risk communication process, and connecting the veterans with services that are available to them. So it's not just checking boxes as a clinical reminder, it's initiating care. This keeps kind of going off by itself, but that's okay. And we use this acronym, screen and serve, and the serve part was we screen the veteran and then we provide supportive education and resources for veterans. So what's it accomplishing? The challenge we have with Lahaina as well is we say, well, there were lots of exposures and we don't know how much you were exposed to, and so, here's some information, but there's really not that much we can do at this point. except keep an eye on things. Well, we can do better than that. And what we're saying is we are affirming that you were certainly exposed to things. So it's an affirmation. You're concerned about it. We're concerned about it. So it starts with an affirmation. It gives them information on the presumptive conditions, gives them guidance how to access claims and so on. We have a lot of social workers involved with this and case managers and that sort of thing. We provide them with information about the registries, standardized information on the exposures, and we put it on the problem list. So then we can say, okay, so as long as you get care in the VA, one of the elements on your problem list and on your risk profile. Everybody has a risk profile. You smoke, what do you eat, BMI, all these things, what the genetics, the family history. This goes on your risk profile also. You were involved in the Lahaina fires. You were there when it happened. You were there to sustain whatever sort of contamination was there before the fires, after the fires, and so on. That goes into your risk profile. So we're getting away from saying, well, did it cause this? Did it cause that? Down the road, we may know. But one thing we know for sure right now is it's a risk for you, and we're going to document it and put it on your in your medical record. So I'm going to just zoom through some things here. It'll be, these things are available to you, and I can provide you with any of this stuff after the sessions as well. I did ask that these not be shared, even though it's all public-facing information and so on. I'm happy to provide anybody with information on individual slides and so on, but because I'm not officially representing the VA here, I decided not to sort of make them widely available. There's nothing on here. There's not public-facing. And we're calling this, and this is the other important point I wanted to make today, exposure-informed care. And so when we talk about trauma, I worked in a community mental health center all these years. Felitti was doing the ACEs studies, and all of a sudden this notion of trauma-informed care. It's not just we're trying to figure out who's going to get PTSD. We're looking at the ways that trauma impacts health, relationships, healthcare utilization. Trauma impacts all those things. Physical diseases downstream, mental health diseases, not just PTSD. Every mental health condition you can think of is higher rates in individuals that have trauma histories, early life trauma histories. Military personnel have higher rates of trauma history before they enter the military. So there's something about that we don't understand exactly why, but so they have traumas before they enter the military, during military, training traumas, combat traumas, sexual traumas, very common, so on. So, and we're calling it exposure-informed care, which means we're keeping this in mind. We're putting it on the problem list. We're documenting it. We're educating you about it. We're here to answer your questions. So should we, maybe I'll just show two more slides because I don't want to totally use up this. So there are some slides here about the different presumptives. Now there are dozens of presumptives for burn pits. There's presumptives for Gulf War illness. Anybody here heard of Gulf War illness? Anybody here heard of long COVID? There's a lot of overlaps. After these life-changing, tumultuous events in people's lives, we tend to have more higher frequencies of medically unexplained symptoms, symptom-based syndromes. That's what Gulf War illness is. So that's another registry that we have in the VA, and also we have benefits for veterans. Camp Lejeune, both health and disability benefits for veterans as well as their partners. So our data, we've screened almost 6 million veterans. 46% of them have some concern. Pie chart shows Agent Orange 24%, burn pits 38%. Unknown is 17%. Now that's a big one because that's the Lahaina group. Because we don't have exposure data and we don't have presumptive conditions. So you can put in a claim for anything, but the bar is very high because it's hard to do exposure assessments if we don't have exposure data. So we can say to this population in Lahaina, of course you're exposed to all sorts of toxic things and still are. But what are we going to do about it? So this combination of science, there is science behind what should be a presumptive and what isn't, but also we have to have policies, we have to have a mission, we have to have priorities in our healthcare systems that say we're going to give the benefit of the doubt to the harmed individual instead of assuming you probably weren't hurt, which is what we told veterans for years. So toxic exposure screening, really what it's about is what did you experience, how's it affected you, how are you doing now, and what can we do for you? And so we're really trying to build trust through this exposure-informed care because we've destroyed a lot of trust in the VA. And it's all based on this thing in Ahmed called the precautionary principle, which means if you don't have exposure data and there's any evidence of harm, stop. Don't say, oh, it's probably not hurting you. Look what happened with tobacco industry, with opioids. We knew there's a problem. Stop. We kept going. And just because science didn't give us the data to prove that this individual's addiction was because they were getting opioids inappropriately or whatever. So the precautionary principle gives the benefit of the doubt to the potentially harmed individual. And this whole presumptive approach means that if you were in the same area as the chemical, then we're presumed you were exposed. And the idea of using you were doing this job or that job, there may be a bearing, but what we found in the military or in the VA is that the best proxy for exposure is if you were in the same place as the chemical at the same time, we presume you may have been exposed, presumptive exposure. And then this whole issue of designating presumptives, it may change in the next months too. Who knows? You know, because this is a real different way of going about things. So exposure-informed care, you're doing a lot of this. You're listening, you're learning, you're starting with the individual story. You're putting together services for them and educating them in risk communication. So the last point I wanted to make was, we talk about social determinants of health. In the next 10 or 20 years, everyone's also going to be talking about physical environmental determinants of health. Where have you lived? What's the air quality been? What's the water quality been? Are there additives in the baby food? Are there, you know, so every population there will be some physical environmental determinants of health that will be a standard part of screening, depending upon where you live and depending upon what sort of stuff you've been doing in terms of things you've been exposed to. So I just use the term physical environmental determinants of health. You know, determinants of health and physical environmental determinants of health. So that's the essence of what I wanted to say. And I'm sorry, you know, we've used up half of the coffee time. But, and I'm happy to answer anybody's questions for the rest of the session or down the road. What? Yeah. I wanted to make one other quick comment. There was a recent article in JAMA calling for exposure. They don't call it exposure-informed care yet, but they will. Calling for essentially adding this as a dimension to healthcare. Well, I forget what they call it, environmental determinants of health. Environmental determinants of health, yeah. So that's in the, I have a list of references for you. And this is another one, JAMA, recently that I loved. And it was like just a couple of weeks ago about this idea of some of the cultural realities here that aren't just something to be sensitive about. It's something to help us drive forward and find the right path, both the healing for the community and the future of the community in terms of the health and well-being, not just of the people, but of the climate. And so you're doing a remarkable job. And here are the references, and I would recommend all of them, and they'll be available to you.